just one of the many, many scams which has evolved over the past 30 years to take advantage of the sick and vulnerable. And it's absolutely morally repugnant.
I mean, that kind of spread you don't see anywhere else with any other product. And it's happening because there are many people marking the price up so that what is $400 when it leaves pharma could be marked up to $4,000 by the time it reaches the patient.
If you could first introduce a little bit about yourself so people know who you are. I know you've done so many things and you're a specialist in your field. If you could introduce yourself, that'd be great.
Sure. So I'm Vincent Rajkumar. I work at the Mayo Clinic and I'm a hematologist oncologist. And my disease specialty is multiple myeloma. I do research, education, and practice as far as myeloma is concerned. I also have an interest in drug pricing, which started because I run a lot of clinical trials and work with new drugs. I do studies on racial disparities, so I'm aware of the impact cost of medicines and healthcare has in various communities. So those are some of the things that I do. I also edit the Blood Cancer Journal along with my colleague, Dr. Takeri. So, when it comes to drug prices, there's impact on the patients who are the people who are actually affected by with disease, as well as the cost of taking care of the disease. And there you hear not only from patients that I myself treat, but also from patients across the country. I wrote my first paper on cost of prescription drugs in 2012. And it was focused on cancer, the high price of cancer drugs and what we can do about it. And it was mainly because, I worked on thalidomide, which was the drug that was banned in the 1950s because it caused teratogenicity. I probably am the only physician in the world who actually used thalidomide to treat leprosy, which it was approved for, and then also subsequently started using it for myeloma. So I was there in India using thalidomide for leprosy, and it was given to us basically free of cost in huge buckets that you could use to treat patients. And then I come to the US, and then I find thalidomide costs $10,000 a month. This drug should cost $10. And then I see the price of lenalidomide, and I see the price of lenalidomide launched at around 4,500 and then going up every year to 5,000, 6,000, 8,000, 10,000. And you're going like, what's happening? And so that's when I said, I really need to understand the root cause of these problems. And the more you delve into it, you find it's not simple. And that's why no one's able to fix it. Because it starts with the monopolistic pricing, and then there's the middlemen, and then there's the whole infrastructure. You just don't even know where to start if you want to fix something.
Thank you for sharing that. Alex, before we dive into this really incredibly interesting and sometimes infuriating topic, I'd like to point out that you are a practicing physician. So you're trained, you pursued medicine, and at some point, you pivoted a little bit and you thought, I got to do something else. Can you share a little bit about, one, the inspiration for getting into medicine, and two, that catalyst where you thought, I have to pivot here?
Yeah, no. So my background, I'm a board certified diagnostic radiologist, have a PhD in applied mathematics. When I was a kid, I was going to be a string theorist, so a high energy particle physicist. I was being fast tracked into that. Just with all the wisdom of like a teenager, I decided that wasn't going to be impactful enough in the real world. So made a hard shift my last year of college, and yeah, decided to major in biochemistry instead, and graduated at the age of 18 and went on to medical school. And yeah, I completed an MD PhD program. Yeah, while I was at Hopkins, I was working with a pulmonologist on a research project, and one day he came in infuriated because two of his patients had died over the same weekend. They had both needed a drug called Bosentan, which is a drug that treats a condition called primary pulmonary artery hypertension. So hypertension specifically of the big blood vessel that comes out of the heart and goes to the lungs. And they both needed it urgently. The medication at the time cost $10,000 for a month's supply, despite the fact that it was long off patent, was a generic product at that point. But yeah, they were meant to apply to a patient assistance program set up as a nonprofit by the manufacturer who made the product. And yeah, we just got caught in the red tape. And both of them, tragically died in the same weekend. Yeah, so I had been angry about these topics for some time, and you think that'd be enough to set me off on kind of what wound up happening. But really, kind of the straw that broke the camel's back was, do you remember Martin Shkreli, the so-called pharma bro? In case any of your listeners don't remember, or maybe too young to remember at this point, it was way back in 2015. He was sort of a social media villain of the day type guy. He was a hedge fund manager who took over a pharmaceutical company and increased the price of a drug called Daraprim, generic pyrimethamine, primarily used by indigent patients who are immunocompromised by over 10,000%, hundreds of dollars a tablet. And yeah, became sort of, became sort of a villain of the week, and I got very mad, and some of my friends did, and who are also doctors, and we decided very naively, hey, let's set up a nonprofit pharmaceutical company that will make drugs, sell them at cost. And yeah, went out for, while working as a doctor for the better part of, 3-4 years trying to raise funding for the nonprofit, and did not succeed, failed spectacularly, raised $0 beyond what I put in myself. Eventually got talked into converting it to a for-profit public benefit corporation. So a for-profit company, but with a registered public mission with the state. And yeah, eventually sent Mark Cuban a cold email. I sort of sent it on a whim, and yeah, surprise, surprise, he reads all his emails, and rest, as they say, is history.
There is this path, right, that goes from the pharmaceutical companies with the research, the R&D, and developing these drugs, to the pharmacies where you and I are going to go pick up the drugs and the prescriptions. Could you summarize what happens? What is in this path here?
Sure. So essentially the path is incredibly complicated. It's very convoluted, and that's by design. Essentially, there's a layer of financial engineering that takes place between you and actually purchasing the product. Now, to break it down a bit, these entities, pharmacy benefit managers, effectively decide are firms which are outsourced to by insurance companies to decide which products are covered by insurance. They manage all the payments. When they were initially started back, in the 1980s, before computers were as widespread, they were initially there to literally process the payments. They would get paid 15 cents to do the paperwork when a prescription insurance claim was submitted. What they realized over time was, since we're paying for the drugs anyway, we can sort of collectively bargain for the drugs. And they turned eventually into effectively negotiators for drug prices, which sounds good. They're meant to, but eventually what they realized was, well, the way we're getting paid is we take a percentage of the savings. That's how they structure it. So the best way to make the most money was for the drugs to be as at high a price as possible to start out with before they started negotiating down. Kind of the analogy I use is, imagine you wanted to buy a Toyota Camry, but you hate negotiating at the car lot. It's miserable. Everybody hates that. So somebody comes up to you and it's like, hey, I will do the negotiating for you. And in exchange, like I get 10% or 20% or whatever of the amount of money I save you. And you're like, you know what? That's worth it to me. I hate negotiating. So the negotiator comes back and says, hey, amazing news. I got you a great deal. I got you 90% off of your Toyota Camry. And you're like, oh my God, that's amazing. How did you do that? And I'm really, really good at negotiating. Come to find out, the sticker price on the Toyota Camry was $1 million. And you're paying $100,000 for your Toyota Camry, plus the fee from the negotiator, which is another $90,000. So you're paying $200,000 all of a sudden for your Toyota Camry. So that sounds like a crazy over-the-top example, but it really happens. The sort of example drug that I use all the time, because it's sort of the most extreme edge case, is a product we offer called imatinib, which is a chemotherapy product. It's a tyrosine kinase inhibitor for chronic myelogenous leukemia, and you need to be on it for many, many years. And the list price, the so-called average wholesale price, is $10,000 for a month's supply. Now, the PBMs will, if you get it through your insurance and you have a high deductible plan, it'll be adjudicated at between $2,000 and $3,200 as the negotiated discount price plus the margin for the PBM, what have you. Meanwhile, if you get it from the Mark Cuban Cost Plus Drug Company, it's $39 for a month's supply. So that delta between 3,200 and 39, not 3,900, 39, is being taken by somebody. And it's actually not the pharmaceutical manufacturer. It's by the intermediaries in the pharmaceutical supply chain. And yeah, the taking a percentage of the rebate is just one of the many, many scams which has evolved over the past 30 years to take advantage of the sick and vulnerable. And it's absolutely morally repugnant.
I mean, that kind of spread you don't see anywhere else with any other product. And it's happening because there are many people marking the price up so that what is $400 when it leaves pharma could be marked up to $4,000 by the time it reaches the patient. And unless the patients are aware, you could be vulnerable to high prices, whether it's insulin, whether it's Gleevec, whether it's a new cancer medicine, whether it's an old medicine. What we find is where the prescription goes, how the prescription is written, what you're aware of as far as the coupons and rebates you get can really affect how much you pay for that medicine. And it's not a small dollar amount.
Again, it goes from, for people to really understand, we know about pharma companies that the R&D happens there. There's some price set there. It goes next though to wholesalers. Is that right? Can you describe that path? And it's pharma, wholesalers, and then is it PBMs to the pharmacy?
Yeah, so if it was only that linear, basically the wholesalers do take a markup. Usually, in our experience on specific products, it can be a very, very high markup. So our initial product, albendazole, an antiparasitic drug, it's available actually the price has come down, but it was available from us for $30 for 2 pills. And a complete course of treatment tends to be 2 pills. So, but at the same time, it was, as far as we could tell, about $70 a pill from the pharmaceutical wholesalers if you purchased it directly from them. So there is a lot of inflation that happens at the wholesaler level. And as a general rule of thumb, the price of a drug approximately doubles once you purchase from a wholesaler. But, that sounds like a lot, and it is, and, it's perhaps a bit too much. But at least they serve a function. They're like FedEx, they're like UPS. They send the products around the country. Yeah, the best way I can probably describe it is it's basically a pile of spaghetti with lines going every which direction from all the various different actors, PSAOs, GPOs, the insurance companies, the pharmacy benefit managers, patients, about the way money winds up flowing in the pharmaceutical industry. And kind of, the way I think about it is this is a feature, not a bug. The system is so artificially complicated that it permits basically theft in the service of it.
If you were to let's just give an example for like a $10 pill. Let's say that's what the pharmaceutical company has set the price on. It's $10. Can you give an example of roughly, this is just, an example of what that could look like by the time it gets to us. So it's $10 here, it goes to the wholesaler. What is it there? If you could just sort of, yeah.
Yeah, around about, on average, it'll be about, probably $20 from the wholesaler. The pharmacy will probably add on. And actually, that's a little, maybe it's even much, but let's say $10 just to keep the numbers round. It's usually maybe more 6 to 8, but let's say at the pharmacy, it's about 30. Then the price manipulations start to happen, and that'll be the net acquisition cost, the actual price, the dead net price, so called, at the end of the day. But there'll be a number of artificial prices put on it, which, depending on if it's a brand name drug, a generic drug, let's say it's a generic drug for the sake of argument. Generally, a generic drug is priced at a pharmacy benefit manager at about an 85% discount. So they will say that the price of the drug is, in this case, $200. So that'll be the price you see if you try to pay cash at a pharmacy without using a special program of some kind. So it'll be artificially inflated to $200 so they can negotiate it back down to 30 and then charge a little bit more for the service of negotiating. So the manufacturer will have to pay a rebate to the PBM, who in turn takes a cut and forwards part of the rebate to the insurance company that's paying the ultimate bill, but the insurance company had to pay the whole thing first. And the wholesaler, somewhere in the mix of all of this, holds the money for 6 months and makes money off of the interest. It's a whole morass. Yeah.
Unfortunately, there's no rhyme or reason for these prices, and patients can really go and play around on some website like goodrx.com. You enter the name of a drug and you order a 30-day supply, you would find a coupon for 90% discount. If you order a 60-day supply, you may get much lesser discount. For a 90-day supply, the dose of the drug, for example, lenalidomide, which is Revlimid. Medicare spends more money on lenalidomide than just about every other drug. The drug costs the same whether it's a 5 milligram tablet, 10 milligram tablet, 15 milligram, or 25 milligram. So you take 2 5 milligram tablets, you're going to be paying double the amount, 36,000 instead of 18. So we have how the prescription is written. I'm giving an extreme example, but many drugs you have to really look at. Taking the drug twice a day just because you want to break it down is not going to be the same price. You'll pay double.
How can there be such a disparity going from point A, which is the same, but in 100 different locations, it's just all over the map?
Yeah, and it's hard to regulate. There is no transparency. If you try to say, let's not have rebates, then the people in the middle could just convert rebates into fees. That this is how much I charge for me to buy the drug from someone and give it to you. And, they can add 5 different types of fees in between so that the price of the drug gets marked up. I think really government and regulators have to take a close look at this. The Federal Trade Commission, they have to really look into who's making profits, what is competitive, what is anti-competitive. All of that has to be looked into. Meanwhile, you and I and patients, what we can do, as well as physicians, what we can do is be aware of the system. Be aware that it's not just simply getting a prescription and getting it filled at the closest pharmacy. Be aware that your copay for insurance might be higher than if you just paid cash for the same drug without going through your insurance company. And that could be substantial. After I posted my tweet, people were posting, it cost me $250 with insurance and $10 cash. Then why have insurance? And so just being aware, and unfortunately, even physicians are not aware of all of the disparities. Says you must be aware of it. Just check, make sure your physicians check. And I tell my colleagues, make sure you ask patients about affordability. Can you afford this medicine? What is your insurance like? How much copay do you have? Just talking to patients and inquiring their situation so that If somebody says, no, doc, don't worry, my prescription drugs are fully covered, I have only a $10 fixed copay, fine, no problem. But if someone says, I pay 5% of my prescription cost as a coinsurance, then you better be careful how much that drug is billed and whether that, you're sending it to the right pharmacy.
As a general rule, the worst prices will be at your big national chain pharmacies. Into the other parts of, buying spaghetti or whatnot. Have that on the mind, apparently. Obviously I'm biased, but I think generally the best, for most products, we tend to have the best price or at least close to it. And the way we do it, so we purchase the product. We are a registered pharmaceutical wholesaler. We buy the products direct from the manufacturers at our flat 15% markup on top of it, a $3 dispense fee and $5 shipping and handling at costplusdrugs.com. And you can get any of about 1,000 generic products from our site as of today, and we'll be adding on brand name products in the near future.
And many, many people are finding out that just going to Cost Plus Drugs and getting the generic might be much cheaper than paying the coinsurance on their through working through insurance, and that shouldn't be that way. And it just doesn't make sense.
What can people do? I know there are so many drugs out there. You talked about 1,000. I'm sure many more to go. What about the people who don't have their drugs covered yet by Cost Plus? I know you're working on that. What can they do at home? What can they do?
Oh, sure. So there's a number of different resources. Always check with the manufacturer website. There may be a co-payment assistance card or other cash assistance program. They might not be the most convenient things in the world, but oftentimes you can get the cash out of pocket you have to pay down significantly looking that way. Discount card programs like GoodRx or Single Care might be an opportunity if they have pricing. They tend to be more generic focused as well, as opposed to brand name products. I think those would be the two easiest things if you need a brand name on patent medication. And generally the easiest way to know is if it has a really easy name to pronounce. It tends to be a brand name medicine. I would Google the name of the medicine and check the manufacturer webpage and see if there's a program available to help you afford it. And if it's a generic one, check costplusdrugs.com. But if we don't have it, I would look for a discount card program and maybe there's a discount available there. Or you can even ask your pharmacy, just can I pay cash and see if they'll, oftentimes the discount cards are unnecessary and they'll just sell you the drug cheaply.
That's amazing advice. Last question. Well, actually, really quickly, the difference between the brand and the generic in terms of the experience here, has it been much harder with one than the other?
Yeah, so the generic companies, it's been easier to get a hold of those products just because there's more of them. So there's more competition and more people looking at ways to get their products across. The brand name companies tend to be not necessarily beholden to the PBMs, but it's a big risk to them to go outside of the PBM structure, which, it's not great. They're not thrilled with it because from their perspective, they do all the R&D, they take all the legal risk, they take all the bad publicity from the public when people complain about high drug costs. And they're like, why are these companies getting a third of the revenue from our products? It's insane. But at the same time, the status quo works for them. So it's a bit of a risk going with us. But I think, in our conversations behind the scenes, they're willing to take that risk at this point. They're kind of sick of the status quo as well. So we'll be bringing them on in the near future.
What is your vision, right? There's the 1-year vision, the 5-year. I mean, what is the next big vision of what this landscape will be like for people?
Sure. So, adding more and more products, brand name products, on a very tactical level, beginning to work with insurance companies over the course of the next year, of course, on our terms. And essentially hoping long-term to change the status quo to, something more sustainable, based on, taking the pharmaceutical marketplace and making it like any other marketplace where you can see what the prices are and make rational, informed decisions as, a patient and as a consumer of, based on real prices instead of make-believe numbers. Like,
This was a huge eye-opening sort of conversation for me as well. Is there anything else you'd like for patients and families to know?
I just want patients and families to know, so, number one, thank God people are taking notice and people are aware. People who are becoming aware that this is a problem and have decided we have to change. People like me, patients for affordable drugs, many others are now taking notice that who are all the others in the system who are not playing well. Pharmacy benefit managers, wholesalers, pharmacies, and we have to advocate for reform in that area. I'm also very happy that people like Mark Cuban have taken it on themselves. Like, I can make a change myself and start a mega firm like Cost Plus Drugs, which started, I think, when the CEO was talking at Mayo. He said he started with 12 drugs, and within a year they've got almost 1,000 drugs at prices that are lower than any pharmacy in the US. So yes, and then now hopefully they can negotiate with pharmaceutical companies and get insulin and brand name drugs. We'll have to wait and see. I don't have any inside information, but patients should be aware that thankfully things are changing and they're changing for the better. And as long as they are aware that prices can be varied and work and physicians are aware, then even within the current system, they can find a lot of drugs, including cancer drugs, at affordable prices.